Good morning, everybody. We're just letting people into the waiting room, from the waiting room. Still, people are still coming in from the waiting room, so just waiting a minute. All right, I'm sure we will get some more people as I'm talking. Good morning, everybody. My name is Maria Thacker-Gothi, and I'm President and CEO for Georgia Bio and CEO for the newly established Center for Global Health Innovation. We encourage you to visit innovateglobalhealth.org to learn about the center and our various divisions that include Georgia Bio, the Georgia Global Health Alliance, our new STEM Institute, and the Global Health Crisis Coordination Center. We're very excited about today's very timely program as the state of Georgia has been reopened now for a few weeks, and we see a number of our companies and our partners and those across our ecosystem reopening their offices and are considering reopening their offices too in the coming months and new ways. I'm sure over the next few months we'll be continuing to harness a lot of digital innovation and technology to make sure we're able to achieve what we need for our clients and our members and our partners and our families. And we do want to, as an organization, provide support to you all and advisement as best as possible as we continue to swim our way through these new waters that we live in. A couple of announcements before we kick this off formally. I would like to thank King & Spalding for partnering with us today, as well as the Global Health Crisis Coordination Center, to provide this very timely program and answer your questions later in the event. But next Friday, we will also be hosting a Global Healthcare Supply Chain Logistics program at 10 a.m. We're excited to be welcoming not only the State of Georgia's Trade Commissioner, but also speakers from some key industry partners within our fine state in Alcon and a few others. So stay tuned for those details. Make sure you're on our email list. If you're not, reach out to Christina, who will be sending a follow-up note after this program is done to thank you for participating and get you the recording. Separately, for those that did not see the news, that do work in the bio industry, the Biotechnology Innovation Organization announced a new CEO that will start in June. Dr. Michelle McMurray-Heath. She's an advocate for innovation, science, and patients, and coming to the industry from J&J. She'll be leading the largest biotechnology association in the world, and I can comfortably say that we're very excited, we as in my counterparts across the country, to work with Dr. McMurray-Heath and help continue to enable and support our company as they not only respond to COVID, but continue to respond and support patients and provide care for patients and populations around the world. So we're very excited to be welcoming Dr. McMurray-Heath to our community, and I'm sure we will be hearing from her at the first week of June during the BioDigital event, that convention. So with that, let's kick this off. Thank you again to King & Spalding. We're excited about everyone's remarks, and we're very excited to hear from Dr. Bryman later on in the program. But with that, I'd like to turn this over to Tom Hawk, one of the partners that we've been working with at the center and the GHC3 for the last 6 months now, to take on this program. So Tom?
Thank you, Maria. First slide, please. I appreciate the opportunity to be with you today. As Maria said, my name's Tom Hawk. I'm a partner on our healthcare team in our Atlanta office. And we wanted to talk about where we are headed towards a new normal. So developing a framework to returning to work. Next slide, please. To table set for the discussion today, we thought it would be helpful to take a step back and from a 50,000-foot view, evaluate where we have been and where we are today and where we will be going in the next few months. And I've used the term nonlinear on the initial slide here. You're going to hear that a lot from a number of our panelists today, and that's because, of course, what the experts are telling us, and certainly what all of your panelists today believe, is that the path forward is not going to be a straight line. It is going to be more like a series of the letter W, sort of moving in a jagged forward progress motion, 2 steps forward, 1 step back, but hopefully generally in a positive direction towards resuming activity while combating the coronavirus. Next slide, please. So it seems almost quaint to look back at some of the headlines from January. I've captured a few headlines from national, international media to give you a sense of progression, remind you about sort of where we've been. Back in January, this was just something that wasn't really top of mind. We were hearing a little bit about it from China. There were some media reports about the outbreak in China, but it certainly wasn't the wall-to-wall coverage we have today. There were other things going on politically at that time, of course. But the outbreak was gathering steam in China, and the first political decision made in the U.S. With respect to the coronavirus, of course, was the travel ban to China at the end of January, and there was some noise around that. But for 3 or 4 weeks after that, we didn't really have any developments in the U.S. in terms of the coronavirus, except for 1 or 2 cases, or a handful of cases, rather. On February 22nd, though, there was a front page article on the Wall Street Journal that said there was an outbreak in northern Italy, and that was really the beginning of it coming to the Western world in large part, aside from a handful of cases. And after the outbreak in Italy, within a couple weeks, of course, it jumped over here. The first case in Georgia was in early March, and by the middle of March, there was a travel ban to all of Europe in place in the U.S., except the UK, I think, didn't come online in the travel ban until a few days after the initial ban. Georgia actually closed schools relatively early in the process, certainly before New York. Mid-March, the schools were closed. March 23rd, the first limited shelter-in-place order went into effect for all of Georgia. The city of Atlanta went into shelter-in-place order on March 23rd, a broader shelter-in-place order with respect to the city of Atlanta. And then a week later, Governor Kemp put in a shelter-in-place order for the whole state. And by and large, most states did it, a week or so in advance of that. But by and large, by the end of April, the states that went under shelter-in-place orders had done it. And so for 5 or 6 weeks, next slide, please. That's where we were in a shelter-in-place. In the middle of April, the political conversation began to shift just a bit to discussions of the reopening process. That gathered steam towards the end of April. The White House released guidelines about a phased reopening approach that was very structured, and some states have used that phased reopening approach. Other states have adopted more flexible approach, including Georgia. Governor Kemp allowed the statewide shelter-in-place order to expire at the end of April, and a week prior to that, he had allowed certain personal care businesses to open. And so, end of April, we are starting the reopening process and moving towards sort of the new normal. Next slide, please. I was searching for a metaphor to describe sort of where we find ourselves. The words unprecedented just don't seem to capture it. And Maria, in her intro, I think, dovetailed nicely. She used the term uncharted waters into my metaphor, and I didn't ask her to do that, but she captured exactly what I was trying to convey with this. And I liken the situation we find ourselves in to a below average swimmer being dropped into the deep end of the pool and told to make it to the edge. This person has swam before, is not going to drown, but has got to sort of dog paddle their way to the edge. We can see the edge of the pool, but we've just been dropped in, and we've got to sort of figure out how to get there. And next slide, please. And the reason why this is so challenging is that there are so many unknowns as we thrash about trying to find our way to the edge of the pool. Dr. Bremen may touch on some of these in a more substantive way, but wanted to just capture this slide for purposes of saying, there's a lot of things we don't know. We don't know about the coronavirus, related to immunity, related to effects on kids, related to effects on African Americans, and the ability of this disease to be contagious in asymptomatic individuals. In addition to that, we don't know what the collateral impact of the shutdown orders are. Even from a public health standpoint, there is a cost to extended lockdown orders in terms of mental health, delayed vaccines, et cetera, aside from the economic issues. And so all of that we're sort of swirling and having to deal with. And finally, next slide, as business owners, generally trying to avoid politics is a good mantra, because politics sometimes is not good for business. But unfortunately, politics has infected everything in American life, including public health decisions and the decisions to reopen or not reopen. And so, of course, business owners need to be aware of politics of particular decisions they may make, and how that may affect their business strategies. And so that's just one more challenge that we have to deal with on the path to reopening. I'm going to turn it now to Dr. Bremen to talk more about where we are in terms of a public health standpoint. Dr. Bremen.
Thank you, Tom. Good morning, everybody. Can I have the next slide? So I'm going to also take you back to early to mid-May, when the country became full of junior epidemiologists in training. And we all learned the term flattening the curve. And the point of flattening the curve, by reducing, by increasing social distancing and reducing the potential for the virus to be transmitted, was to essentially try to help the health system absorb the shock and to avoid excess cases requiring hospitalization and intensive care and ventilators that might lead to increased mortality, and also would pose increased risk for healthcare workers. So next slide. And the flattening the curve effort took time, but it largely was effective. These are data from Georgia, from the Georgia Department of Health, that shows pretty much by mid-April in terms of cases, and the number of cases is subject to a variety of biases related to how many tests are being done, but in essence, the number of cases in Georgia flattened. In the last 2 weeks, Georgia maintains a 2-week lag period, so there isn't really such a dramatic drop probably, but the curve has been flattened. A better indicator of what the impact is of COVID and what whether or not you've been successful at flattening the curve is hospitalizations. And looking at data from Arizona, you can see by the end of March and certainly into April, there was a flattening of the hospitalization curve, the number of cases occurring each day. So there was a success at this, and we never expected, when we were talking about flattening the curve, that would mean eradication of the virus. It again was an effort to allow the health system to absorb the shock and to basically also improve the way the patients were being cared for. So it enabled clinicians to get more experience with coronavirus. They learned how to take care of patients in more optimal ways. It bought time for the introduction or the development and introduction of therapeutics, which has begun to happen. And it hopefully has brought us closer to a time when we would have vaccine available. Next slide. And we've also had an opportunity to learn a little bit about what the risk characteristics, what populations, what factors are associated with both infection and for bad outcome from coronavirus. And these are data from Illinois focusing on really just one issue of race and ethnicity. And on the left, as a cluster of bars, you see the proportion of the population that is African American in Illinois, which is about 15%, and the proportion that is Hispanic, regardless of race, approximately 17.5%. And then when you look at the confirmed cases, though, there is a disproportionate increase in those that are African American. It goes up by about 1.7-fold. And you can see a dramatic increase, almost threefold, in the proportion of cases in Illinois that are in Hispanics. And then getting concerning and interesting is if you look to the right, the ultimate arbiter of severity of the outbreak, mortality, that not only are African Americans at increased risk in Illinois of becoming infected, but then they're in dramatically increased risk of dying. So accounting for, despite the fact that only 15% of the population is African American, more than a third of the deaths are represented by African Americans. Interestingly, in Illinois, and this is not necessarily true in all states in the US, the proportion of deaths that are among Hispanics drops. And the difference here in Illinois probably relates to differences in age and underlying medical risk categories that are characteristic of the populations in Illinois. It is different, for instance, in New York City, as an example. But this information is just one kind of example of the importance of understanding more granular, at a more granular level, who is at risk, and that will enable strategies at some point to minimize the risk as we ease up and reopen up workplaces. So next slide. So again, the goal of the lockdown and of flattening the curve was not to eradicate the virus. Nobody in their wildest dreams expected that. The idea was to get to a point where there could be an intersection of public health and economic health, and where we are in the second box, where there are now changes in these control measures. We're easing up, workplaces are opening, other kinds of community activities are opening up. And the question before us all, and a focus of this discussion, is how to keep the onward curves as we move to the right, either flat or not rising substantially. Tom mentioned that we can expect W's ahead, and I think he's right about that. But the goal is at least to make them small W's, not to have major increases in surges in cases that once again would strain the health systems, overwhelm them, and put everyone at risk. So the effort is to find the most efficient, most effective ways to minimize the risk of transmission, for instance, in the workplace. Next slide. And okay, this might be animated. Okay, and so and there are a variety of approaches that are summarized here, whether you temperature screen or do other kind of screening. Next, promoting hand hygiene stations in the workplace, finding ways to continue to social distance and to minimize the size or frequency or closeness of meetings. And the single most probably effective way to minimize transmission in all settings at this point in the pandemic will be wearing facial coverings, because that, as source prevention, if you will, if someone is asymptomatically infected or mildly ill and somehow comes to work and is shedding the virus, the wearing of masks will dramatically minimize the risk of that virus being passed on. And then another thing that we at the Global Health Crisis Coordination Center will be working on with our partners in industry, as well as legal and ethical and public health, is the role of diagnostic testing in the workplace. You know, at what cadence and what focus should diagnostic testing occur depending on the type of workplace. Next slide. You know, one thing to be aware of is that, that there is the question of what proportion of us now at this point, you know, here we are in mid-May, the outbreak has been ongoing since, you know, for more than 2 months now in the United States. How many of us have been exposed? And what proportion of us are hopefully then, once exposed, immune? And we don't know what that number is, or that proportion. And it's an important thing to know as we consider opening up the workplace and our communities. And so I've back calculated for you so that you can get an idea of how this looks. So if currently in Georgia, for example, there are up to current, there are approximately 1,500 deaths. Next. If you assume a 1% case fatality rate, and that's what is often assumed for COVID, that would mean, just doing the math, that to get to 1,500 deaths, there would be 150,000 cases. The population in Georgia is 10.6 million. If there are 150,000 cases over 10.6 million, that would mean that 1.4% of us have been exposed and are immune, which means that 98.6% of us are still naive to the virus. If you get more aggressive about it and assume that the case fatality rate is really 0.1%, which is possible if you consider asymptomatic infections, then you still would have 1.5 million cases over 10.6 million, or 14% that have been exposed and potentially immune. And next. And that would mean, next, just click one more time. And that would mean, therefore, that somewhere in between, and I suspect it's a little towards the high side, that 86% and about 99% of the population has not yet been exposed to the virus and is not immune. It's an important thing to reckon with, because in a lot of ways, we're just beginning in terms of what will need to happen with prevention, how we're gonna have to tune up what we know and what's logical as we approach this next phase. Next slide. So again, the goal will be to keep that onward curve flat, or if anything, only slightly and occasionally rising. And that's going to require the kind of thinking that will go into this webinar, and interventions and modification of those interventions as we learn more from the workplaces to continue to control this problem. And that is it for me.
Great, thanks, Rob. This is Zach Harmon. I apologize I don't have my video on. I'm having some troubles with my Wi-Fi. Hopefully this will work. So it's good to be with all of you today. I'm a partner in King & Spalding's Washington, D.C. office. I've spent my career back and forth between private practice and the government, and I'm a member of our firm's COVID-19 task force. And in connection with that, I've been spending a lot of my time helping clients to develop return to work plans. So today I'm going to focus on just one part of the broader return to work challenge. And that's the challenge that's presented by I use the term patchwork of legal and regulatory requirements that has been emerging around these return to work topics. And I think patchwork is exactly the right term to use, because the pieces, as I'll describe, really don't fit together very neatly at all. And more than that, I think this is fair to say at this point, there's really no overarching organizational structure for the requirements that are emerging. So to illustrate my points, I'm going to use the example of screening, which is one of the issues that most companies, if not all companies, are confronting as they're working through return to work issues. And the basic questions around screening are two. The first question is whether you want to screen people that are entering the workplace. And the second is if you are going to screen people, how are you going to do it? And so like basically all of the return to work topics, these screening requirements are being developed at a variety of different levels. They're rolling out at the state, county, and even city levels. For those of you on the phone in this meeting who've been able to operate as essential so far, you know, you've seen this. Many, if not most, of the stay-at-home orders rolled out, at least initially, at the city and county levels. And I think there's a consensus, maybe a growing consensus, that that's even more likely to be the case with respect to returning to the workplace. And the reason really goes to what Dr. Bryman was describing, which is that these health issues, they vary from community to community. And so the return to work decisions, which are, for obvious reasons, heavily predicated on the public health issues, they're also going to have to vary from community to community. So what does this mean? I guess in a sort of a simple form, it means that you're not just going to face different requirements, you know, in different states like Georgia or Texas, but you're likely to face different requirements at the city level too. So the requirements in Dallas may be different than the requirements in Houston, for example. And I want to pause for just a moment on this word requirements, because I want to be clear about this. The city, the county, the state directives that are rolling out and will be rolled out going forward, these are requirements. These are not guidance. Companies are going to have to meet these local requirements if they want to stay open. And those of you who've been operating as essential businesses, you've probably been dealing with this already. And the way that these local requirements are policed, they have inspectors, and that's everyone from health inspectors to police. In some case, we've even dealt with firefighters. They basically show up at your business. They check to see if you're following all of the relevant requirements. And then if you're not, they can shut you down. And what this means is that you're also having to basically deal with the reality that different inspectors may interpret the local requirements differently. And as I mentioned, sort of in connection with the screening example, there are lots of ways to conduct screening. We'll probably talk about that. I think Josh and Catherine are going to talk about that in just a moment. And if we don't, we'll get into it when we talk through some questions. Importantly, going back to Tom's point, everyone should expect that these local requirements are going to change over time. They may loosen, they may tighten. This is the W curve that both Tom and Dr. Bryman were referring to, but whether it's going up or down, the requirements are going to be changing. And that's at the local order level. So moving on to a related topic, in addition to these orders, there are a handful, maybe more than a handful, of federal laws and regulations that come into play just when you're talking about screening. There are obligations under OSHA, under the Americans with Disabilities Act, and a variety of other laws and regulations. And then just to sort of keep this short, my final point is that a number of agencies, and this is at both the federal level and at the global level, have issued advisory guidance on these return to work topics. So we're getting a little bit of reverb. On the screening, the CDC, the WHO, a variety of others have issued guidance. And while the guidance doesn't rise to the level of a law or a community requirement, for example, under one of these local orders, but the guidance can be really helpful in deciding how to protect the health and safety of the people that are in your workplace. So, you know, I think we're going to speak a little bit to liability and, you know, sort of liability exposure issues in a bit, but you can assume that people who get sick in the workplace are going to point to not just the requirements, but also the guidance. So I'm guessing that this all, you know, these are all issues you've been thinking through. I'm sure they seem a little daunting, if not a lot. But the good news is that, you know, companies that have stayed open have been managing through these issues for weeks and in some cases months. I've been working with a variety of companies, as have my partners on the call, across a wide range of industries, and we've seen that this is absolutely manageable. And I'll note that those of you who are on the phone, have a number of advantages in this respect. I mean, first is that you've got access to people like Dr. Bryman. Public health expertise in this area is going to be absolutely essential, because you're facing lots and lots of choices that are really going to be based on public health considerations, not legal and regulatory considerations. And then second, you're also going to be able to draw on the experiences and the best practices of other members of the organizations that are represented on the call, CGHI, the Metro Atlanta Chamber. And while each of your issues and your sets of issues are going to be different, because your business models are different and you operate in different geographies, many of the best practices that are being employed by other companies on the call and elsewhere absolutely will translate to what you're doing. So I, like others, be happy to answer questions when we get to that part.
Hey folks, this is I'm Josh Kamen. I'm the managing partner of the Atlanta office of King & Spalding. I work very closely with Zach and Tom and Catherine and others on our return to work protocols. And given all of what you've heard, I should also say before I get started, I'm also, because of my role at King & Spalding, I'm also in charge of our return to work protocol and helping to manage that with a team in Atlanta in terms of what we'll actually be doing and how it works. After hearing all of this, I'm sure what you're thinking is candidly what I had been thinking before as well too, which is, well, how do you actually make this work and happen? How do we actually get something practically in place that makes sense to deal with all of the moving parts and the moving pieces, and to do something that's tangible, practical, and can actually work for you? Just as an aside, what I'll tell you is that we've been counseling a number of different businesses in this regard that all look different, from large financial institutions to real estate developers to universities to startups, you name it, to nonprofits. Across the board, everybody has a different viewpoint, everybody has different concerns, everybody has different angles that they need to think about. But there are a couple of common consistent themes, and what we want to talk about is giving you today at least some essential insight into what some tools are for you to be able to stake plans and make the most effective return to work as possible. And so as you look at the screen here, in terms of two concepts that we want to talk about, which are first and foremost guiding principles and what they are and what they mean, something that I think will prove helpful to organize and staking some of these issues, and then the actual execution plan, and what you have to have in the plan in terms of the squad, the rules, regulations, and indicators, and then the protocols. So let's move to the next slide if we can. So let's just start, before we start talking about the guiding principles. As we're framing this issue, there are a myriad of different things that we all have to be thinking about. You know, it's questions like who returns and when, and how do you deal with sick people, and how do you implement protocols, and how do you protect yourself from illnesses, and what about these overlying rules that I have to follow and the laws, and what if you have an outbreak? All very complex questions. The one thing that we found that's been really helpful is that for each of your organizations to sit back and think a bit about what your guiding principles might be in terms of approaching each of these issues. It is a little hokey, and I'll admit that up front that it may seem that way, but actually what we found in practice is it's incredibly beneficial. So we're talking about well thought out, upfront standards and that guide discussions and decisions, somewhat of a mission and vision statement. And that if you're going to depart from them, you're only doing so after really making an affirmative, intentional choice to do so. And then how do you use them? Well, you'll use them whenever you're making any decision that ties back to a concept. You know, if an issue comes out of left field, if you have a problem you haven't thought of, at least now you have a common theme and a common thread to go back to. And again, the goals of this are to do what we find the best crisis managers do, which is set up a program that reduces the liabilities, creates greater efficiencies, and provides social comfort. So, just to go one level down, what are we talking about here? We're talking about blocking out concepts and for you really to think about setting clear expectations for things like, what is your intention for work from home balance with return to work? What are your clear expectations about customer safety, business continuity, timing for return, your leadership framework, your communication parameters, your community impact, your visitor events and policies, and your approach, really having some guiding principles about what you think about. So to give you an example, we've talked to some folks who have said it's imperative to them that they move back into the workplace quickly and with great emphasis on engaging people in their workplace because it's incredibly dependent on their business, and they feel a tie and a need to the community to make sure that they're up and running quickly. We have other organizations that are at a different point in that curve or their continuum in terms of where they come back, which is to say, we have an intention to get back as quickly as we can, but we want to move conservatively with the idea of minimal exposure to our people. And that's sort of another end of the continuum in terms of when you come back. But by having these principles in place, when issues come up like, person X asking the question, well, why can't I come back into the office? Or, person Y says, what do you think about me coming in if I kind of am not feeling great, but I have these protections? You can go back and say, look, we have these guiding principles and this is how we feel about it. And this is what our expectations are. So from a guiding principle standpoint, again, happy to talk about that a little bit as we go further, but we strongly encourage everyone to do this, in particular because it'll really help you, call balls and strikes when the time comes in your execution plan. Let's move to the next slide, which is our last slide here. In terms of what that plan is, and just to be clear about it, it's important for us to make sure that as we're talking to different groups that you have in your plan, three key components in place. You want to make sure that you've got clearly identified your squad, as we call it, which is your leadership team and who they are that people will look to, and particularly for messaging. Your decision makers, which may be an overlap of that team, but more in terms of who's making decisions about what and how. And then, of course, your experts. What we've actually found is that A and B are things that are pretty easily identified for many. But when it comes to experts, the basic standard for return to work in terms of liability risks and minimizing those is to have a reasonable person standard in place that whatever you're executing and doing is reasonable in light of the circumstances. And my goodness, having great experts, be they public health experts, outside experts, particular experts that weigh in, that validate whatever process it is that you have in place in your protocols, extremely helpful. So as you think about who your squad is, thinking about it with this framework is pretty helpful with these different groups. Zach had alluded to before the great differences of the rules, regulations, and indicators. At a high level, I tend to think about them in three buckets, which is there's government indicator or government rules really, and regulations, laws, protocols, and the like. There's social indicators, which are things like are schools open or closed? Is public transportation working? How does travel work? And then there are health indicators, which are items, including what Dr. Bremen referred to before about, do you have, what's your hospitalization rate? What's your case reporting rate? What's your death rate? What's the testing availability, the hospital capacity, things of that nature. So as you start to think about what your indicators are, and you can see sort of how this plays out, a viewpoint of your guidance, guiding principles overlaid with where the indicators and the rules, regulations, and indicators fall, then get into what your protocols are and how you execute and follow. So, and it helps your squad make those decisions as they need to. So just again, moving quickly through this because I do want to save some time for others. When we talk about protocols, what do we actually mean? Well, I'll read you a list of the protocols we have. For some clients, we've developed up to 23 different protocols that they have in terms of return to work, but they basically follow the categories of some form of compliance and guidance, communication protocols, business continuity, real estate, operational supply chain, employment HR, compensation, outside office factors, and enforcement. And all of these are protocols that we encourage folks to put into place tailored to their particular situation that help you decide then how you're going to impact and affect return to work. So let's give an example, and we'll go through two, and I'm going to bring in Catherine here in a second to work through this, but let's just make an easy one. Let's talk about access. So if you're coming back to work and you're bringing people into your space, there are 5 or 6 different general protocols that you could put in place as it relates to access and checks. So for each individual, you could require that individual to have a doctor's note in order to be allowed back in the office place. You could do your own health check screenings, be it through temperature checks or otherwise. You could have each of those individuals sign waivers in terms of risks of coming back to work. You could have them deemed to sign waivers by basically agreeing that every time they use their access card to access your space, they're deemed to have signed on to a waiver. You could post signs that say that everybody understands by coming into the space they're assuming risk. You could do nothing. And all of those are actual affirmative protocols that, depending upon your particular situation and your particular need, you might decide one of them is actually the best. And where it gets a little counterintuitive is that while we may all think for you that, of course, the most significant or stringent test might be the best test or to follow, in actuality, it may actually not be for your particular organization. So for instance, if you're going to do temperature screens and you decide that that's something where you need to be, will it be a medical professional that does it? Will that person, if they're not a medical professional, be trained? How do you administer that? How do you actually do that? How do you chart it? What happens if you find a positive test? Somebody is over 100.4 temperature. What will you do with them? How does that work? Catherine, can you disclose it, right? How does that work? So, all of these are things that you go back through and need to think about from a protocol that look through the guiding principles and through the indicators to decide where you think your best administration comes out and what works best from a reliability perspective. Catherine, do you want to just speak for a moment about sort of some aspects of that as it relates to the disclosures and the like? And I'll have you come off mute, Catherine. I'm going to go on to mute.
Yeah, I'm going to jump in. You are, right. And I think the development of the protocols is a very, very important part of any back to work, because as Josh just pointed out a minute ago, it sounds very easy to say, oh, we'll screen for temperature. Sure. But if you stop there, there's so many unanswered questions. As he said, what's our base temperature? What is considered a temperature that's going to mean you can't come back into the office? How do we know that's a temperature related to COVID and you have to be out for 2 weeks? Maybe somebody just has a sinus infection and has a 1-day fever. When a course of antibiotics for 2 days is all they need. So you really need to have some solid protocols and procedures in place if you're going to implement some of these kinds of things, such as screening. And on top of that, you also have to be aware of some of the rules and regs that are going to guide a lot of these protocols. The ADA is places a lot of emphasis on confidentiality. A temperature is a medical screening. It's considered one, and the EEOC is going to consider that medical information you're gathering on your employees. So how are you going to protect that? It's required that you make it confidential. It's required that it be in a folder or file other than the personnel file. Employees have to have a separate medical file. under the ADA. And so you're going to have a means to put all of that in place. And again, you've got to have a protocol for how do you protect this kind of confidentiality. And you have to prepare for other kinds of confidential information coming in your view that wouldn't normally. For example, when patients call in sick, employees call in sick, and you can ask them about some of their symptoms to determine if they might have COVID and can stay home, but that kind of information needs to be protected. You don't want to go in the office and say, oh, by the way, John Smith is called in, he thinks he has COVID, so everybody let's take extra precautions. That kind of behavior is going to get you in trouble, not only probably with that employee, but also with government auditors, investigators. So having those protocols in place are not only going to help you keep your employees safe and your workplace going and productive, it's also going to help you keep out of trouble going forward with both government and your other employees. So those are some of the things you really need to think through deeply. And this is where there can be kind of an intersection between the government rules and regulations that are, have to be followed and some of the guidance. Because some of the regulators on the federal side, particularly like the EEOC, OSHA, have said that they will also look to the CDC for guidance. This is all so new, and there's so little information known that the government is scrambling as much as everybody else. And so they have said, if the CDC is taking a recommendation, we will consider that to be a reasonable precaution to be taken on your part as an employer, and we won't come after you and think that's discriminatory against your potentially disabled employees. So again, there can be some intersection of the guidance with the law, and that's another thing to be aware of.
Yeah, and I think, in summing this sort of back up, and maybe we can open up to questions because we're already starting to get some, one size does not fit all in terms of your protocols. And again, the goal for everybody, I think, is to make sure that your particular organization has the appropriate protocols in place. But I think the lesson maybe out of this is that rather than starting with the protocols themselves, it's been our experience that the best way to build up to the appropriate protocols and what your choices are that you make are to start with, guiding principles, a good handle on what the rules, regulations, and indicators are, making sure that your squad is in place, and then putting these in place. So it's a staged process, but with a good, like everything, with a good sound foundation that you're approaching it, you can then put these protocols in place that not only will be as sound as you probably could have them be at the get-go, but will then also be give you a framework through which you can then pivot as you need to as circumstances change. So with that, I guess I'll pause, sort of turn it back to Tom, Marie, and the group in terms of maybe next with questions or other items that folks want to talk about.
Yes, thanks, Josh, and thank you, Tom, Zach, Josh, Catherine, everybody, Dr. Bryman. So we do have a number of questions that come in. I'm going to kick it off with one. This is probably for the legal team. What liability issues do you foresee for businesses that do not take reasonable precautions in the reopening process?
Well,
I can start.
Go ahead.
Oh, go ahead, Tom.
Well, you've already, taking a step back, sort of businesses operate, and we all operate in our American tort environment under sort of a reasonable person standard. And if there is some precaution that would be reasonable to take, and the business does not take it, then there could be liability for any damages associated with that. You're already hearing some discussion at the federal level about some possibility of liability shields in exchange for meeting certain standards for reopening. Of course, making federal policy is complicated and slow, so I'm not confident that anything like that is going to be quickly forthcoming, but we'll see. So in the absence of that, if you've got to sort of, like we're all trying to do, reason through what makes the most sense for your circumstances, see what other similarly situated people are doing in your circumstances, and if those precautions make sense for your business, then take those precautions. I'll throw it out to anybody else.
Yeah, I'll jump in quickly too. What I'm hearing at a lot of these calls with litigators in particular, sort of bottom line is that there's a degree to which people who are sort of tort litigators are at least somewhat optimistic that the tort litigation, sort of traditional tort litigation, may not be quite as terrible as we would all be anticipating. And that's in large part because, causation is difficult to prove. It's hard to know where somebody actually picked up a virus when they're sick. And then, as Tom and others have pointed out, the defense to these tort claims typically is that under a reasonable person test, you have taken reasonable measures under the circumstances, which most companies obviously are doing. So I think on the traditional tort side, I guess we wait and see. There have been some cases filed already. There's at least one big high-profile case in the big box area. I guess we'll see. So obviously, companies that have more interactions with customers and people walking around in the workplace are probably going to have to think through these issues more carefully than others. People in the real estate context, which is where Josh spends a lot of his time focusing, where you've got people who are accessing buildings in lots of different ways, who are members of the public. Then the other issue is on the workers' comp side. And that's a little bit different. There's a lot of concern because the way the presumptions ordinarily apply in the workers' compensation context is that there's a presumption, which is something that's in play right now, whether this is going to remain the presumption, but there's a presumption that if someone is sick from a workers' comp standpoint, that they got sick in the workplace. California and some other places are sort of fiddling with that presumption because it's obviously going to mean a lot going forward in the wake of COVID-19. But that's the way it typically operates. And so, there are concerns about whether or not the workers' comp funding at the state level is going to be sufficient and adequate to address all the workers' comp claims that could come in. But I think that's what I'm hearing sort of bottom line. Traditional tort issues, wait and see, but hopefully not quite as bad as people are expecting. Conversely, on the workers' comp side, this is going to probably be a mess.
Great. Thank you for that. I'm going to shift to a medical question for Dr. Breiman, because we actually got some emails about this too. There has been conflicting information regarding the benefit of wearing masks. Are there some that do work and some that don't? I.e., if someone wears a bandana over their mouth, does it do anything? If so, what?
So backing up a little bit, and I appreciate that question because there is a lot of confusion about this. The primary purpose of the face covering for non-healthcare workers is what we call source control. So if you have, symptoms, or if you're shedding virus, it's like a sneeze guard in a way. It's essentially blocking virus or secretions that might come from you to get to other people. And most guards will work. What usually people talk about is multi-layered cotton mask, and there are nice descriptions of the various options and how well they work, both as again, source control, which most of them work pretty well. And then some of them give you some protection in terms of what you might inhale. They don't work like, N95 masks like healthcare workers use, but multi-layered cotton masks will probably reduce what you get exposed to by about 50%. But the main function, it's important to realize, is you're actually protecting others by wearing the mask. Great,
thank you. And we don't have much time, so I'm going to go through, we had a few questions from one person. I've heard reports that a percentage of deaths reported from COVID-19 may be skewed, mixed with other deaths that were not truly confirmed as true COVID-19 implication, overlooked, or not substantiated by evidence-based clinical information. Can you comment on this regarding the data if it's not a solid representation. And I'm assuming that's for Dr. Breiman.
Yeah, I guess so, although I'll be happy if anyone else wants to take that question. So the definition of how a case gets classified as a COVID death is fairly straightforward. It's a death associated with symptoms and findings consistent with coronavirus infection, and it's with identifying the virus. So those are the ones that get classified as a COVID death. It's possible that some fraction, small fraction, of those deaths have coronavirus detected, but the death was not really due to. It was finding the virus, but not necessarily causing the death. But I think that's a tiny fraction. And some of the evidence for that is in high mortality areas like in northern Italy, and when this is occurring at its peak in New York City, morgues, hospitals, all the processes associated with death were massively strained. So there was most certainly a dramatic impact of the virus on death. It's also very possible, thinking about that question, a certain number of deaths, especially in people that are have limited access to healthcare, are occurring without interaction with the healthcare system. So that there is a fraction of deaths that have been occurring that are not accounted for. So it's also quite possible that the number of deaths are in fact underestimated.
Hey, Maria, can I follow up on one point that seems to come up in most of these conversations, and I want to make sure we hit it relatively hard today, if that's okay. And that's, we don't want to leave you all with the impression that most of the decisions that you're going to be making, you're making in a vacuum, sort of generally around sort of what you're reading around the public health landscape and sort of what you're seeing, a particular state governor may be inclining towards or not. I mean, there are some really hard, crunchy requirements around what you can and can't do. So when Josh, for example, was going through the litany of different screening measures that people are considering before people re-enter the workplace, you're not, in many instances, going to be making those decisions sort of in a vacuum and on a blank slate, right? To mix a bunch of metaphors. You're going to have to start with, what do the local orders actually say on this point? What is the federal guidance, and what are the federal requirements are on that point? So Catherine made the excellent observation that CDC, more than many federal agencies, is issuing all sorts of guidance around a lot of these topics. It's not law or regulation, but a number of the officials who enforce OSHA and the ADA and others, as Catherine pointed out, are looking carefully at the CDC guidance because it's thoughtful and it's on point and it's recent to decide how they're going to construe obligations within the existing legal and regulatory framework. So for example, with screening, CDC has recommended screening and given the example of temperature screening in areas where there's minimum to moderate COVID risk. It's not a legal obligation, but whether the people who enforce OSHA and ADA and other federal regulations and statutes are going to look to the CDC guidance, I think it's entirely likely. So I guess the point is, you start with, as Josh said, there are some crunchy requirements. You need to understand what those are and then determine, and this is really tough because the orders that are being issued at the city, county, and state level are going to touch on some of these obligations as well. So those change and they may vary even from city to city. But once you understand what the obligations are, then you can really circle the places where you have some discretion. And that's where, guidance from experts like Dr. Breiman and others who have real public health expertise can be so essential in sort of deciding how to make those discretionary choices.
Sure. I'm going to ask one last question because I know we're at time and I'm trying to be respectful. And for those we don't get to, I think I have your names. We'll do our best to follow up via email directly. But for a low-risk organization, and we have a lot of those with pre-COVID-19 telecommuting, would you still recommend testing over questionnaire for the workforce? If that makes sense. That's for a lawyer, I believe.
Yeah, this is Josh. I'll jump in. The answer is probably you could live with the questionnaires just fine. You know, we need to understand a little bit more of the details of where your interactions are and the like as to what you're doing. But again, it's that balance of what are the interactions that you're going to be having with, that your personnel is going to be having with your other personnel, and what is it that's the level of information that you think that you actually need to have based upon what your folks are doing. So if everybody's pretty much working from home and working remotely, I'm not sure why you need to take a temperature check every day other than just to find out the general health and welfare of your people. But, you know, that's probably the right answer for your organization where it comes, knowing what we talked about.
Great. Well, we're a minute past, and we've always been respectful about ending on time. And as everyone knows, we're here as a resource. The organization is, of course, King & Spalding's available, and we're happy to connect anyone in our community to the team at King & Spalding through Tom, of course. And of course, we also have the connection to Dr. Bryman at any point if we need to make that through the Global Health Crisis Coordination Center. So with that, I'd like to thank King & Spalding and the team and Dr. Bryman for preparing today's remarks and being available to our community and for their ongoing support of the Center for Global Health Innovation. Thank you to my team as well. And again, please stay tuned for an invitation and promotions for the healthcare supply chain logistics webinar next Friday at the same time at 10. So with that, no other burning comments from anybody on any of my panelists? Nope, great. Well, I wish everyone a happy and healthy weekend, and thank you again to our panelists, and have a good day. Bye.
Thank you.